the first discussion, our focus will be on how stroke specialists are dealing with stroke patients daily, even during COVID times. On one hand, for a patient, his or her golden hour of 4 hours 30 minutes matters a lot. If a patient reaches at a stroke treating center within that time, a lot of damage can be controlled. And on another side, single stroke specialist has to handle multiple such golden hours of several other patients in order to save them from a stroke attack throughout his day. With this, I would like to introduce first speaker of the session, Dr. Jeyaraj Pandian, Principal and Professor of Neurology, Christian Medical College, Ludhiana, and Vice President of its World Stroke Organization, who would be sharing his experience on chasing golden hours 24/7. So let me begin the session. And my first question would be for Dr. Pandian to know, Dr. Pandian, with shrinking golden hours, chances of reviving a stroke patient can become more challenging. How do you handle this difficult situation to save patients' life?
Yeah, thank you, Mr. Mishra. And it's very important. I just listened to the previous session where cardiovascular diseases, there's been a sudden decline in the number of cases coming to the hospital. So similar trend we observed maybe the first 2 weeks, at least in this region. However, globally, there has been a reduction in number of stroke patients reaching the hospital. There are a few reasons. One is the minor strokes, or what we call transient ischemic attacks. They would think, why should I take the risk of going to the hospital where there are a lot of COVID patients when I have only very minor symptoms? So that is one of the reasons why people were not accessing the care quickly, which they are supposed to do. And the other reasons are probably people's stress level becomes suddenly low, and also air pollution is one of the biggest factor, and people are able to rest and relax, and so many other social reasons that has really helped maybe some reduction in the numbers of stroke patients. But it was only for 2-3 weeks, I would say, maximum 2 weeks, we could see that decline. But after that, what we saw was a different spectrum. Patients who had a previous stroke, a first stroke, then because of the lockdown, they could not get their medication. Then they were very scared to go out and get the medicine. And some of them had stopped medicine and came with very high blood pressure and bleeding in the brain, what we call intracerebral hemorrhage. So there was a sudden spurt of intracerebral hemorrhage, even in Delhi region also, the experience from AIMS, and also in this region. So whether it is related to COVID or not, it's an ongoing debate that in the neurology community and the stroke community we are looking at this. But one of the main reasons was probably, they were stopping the medications that they were taking earlier, or somebody with high BP, high blood pressure, and high blood sugar, cholesterol, they stop medication, and then they have a risk of getting stroke. So this is one in terms of the pattern of stroke patients reaching the hospital. But now the last 4 to 6 weeks, the number of patients almost same like what we had, particularly in our hospital, the pre-COVID. And the only thing that really happened in the hospital setup was, and also across the country, is screening these patients. So we know that the golden hour for giving intravenous thrombolytic treatment or clot busting drug is 4.5 hours. And for stent retriever treatment, it can be up to 24 hours. So overall, if you take that first 24 hours is a golden period, but 70-80% of the benefit people will get if they reach within 4.5 hours. So you need to reorganize the hospital health system. So what happens is, in the emergency department, there is a quick screening of all patients who come in. First is the use of questionnaire. It is across the country. All the hospitals use a questionnaire and see whether they have any, irrespective of any disease, They will look at whether they have any symptoms of COVID or any recent travel. So as a result, what happens? There is some delay. Suppose a stroke patient reaches on time, and then there is at least 30 minutes, 40 minutes delay that is happening because there are so many patients in emergency. You need to triage them and then screen them, and then so once they screen and say, okay, this is not probably a COVID patient, and if it is a stroke symptom, the stroke code is activated. Once the stroke code is activated, the patient goes to a non-COVID emergency, so probably we have lost about 30, 40 minutes in the golden hour because of the screening process that we have initiated. And that is one major change across the country. If you look at AIMS, all the patients coming to emergency are screened for COVID with antigen test. Only if it is negative, no further things happen. If they have a stroke and they have COVID positive, and then dedicated COVID CT scan, which is available, they do scan and then send them to a COVID designated area. So stroke patients, if they are COVID negative in the beginning in the screening, and they go to the non-COVID emergency, and all the treatment begins there. So there is already a minimum of 30 minutes delay is there. It's somebody who comes within that golden period. And then you need to have a separate pathway where you take these patients, because it is it is a screening test, but you're not done any throat swab or any blood the antigen test. So still you need to treat all people as suspects. So you need to have a separate pathway. You need to take them to the scan. So the prime period of about the initial evaluation we lose, and once the stroke code is activated, then all the things follow. So that initial days we were able to miss a lot of patients who came within the window period, and then there was a lot of delay. But with constant education, even in the COVID screening area, we tell them if it is looks like stroke, quickly screen them, and then send them to the non-COVID area. And there also we have trained the emergency department staff, the doctors, nurses. Once the stroke code is activated, immediately they are mobilized. And in the scan, and then we take a decision. And in the stroke unit or neuro ICU, again, people have to take precautions. So the doctors, nurses, they need to take precautions. Sometimes patients are unconscious. And so one thing we try to do is, when the CT scan of the brain is done, a CT scan of the chest is done simultaneously. In a patient we suspect whether it could be. So early you can pick up early changes in the lungs with the same, you do the brain CT and the chest CT. So that will that helps us to pick up the COVID patients early. But it doesn't happen always. So we have to be very vigilant. And recently we had one of the stroke patients, first he had a stroke at chest infection, became well, went home, and then deteriorated, came back because he had a stroke. They quickly screened, they said this is not a COVID patient. So we have to admit, and he was in frank septicemia, that is infection, chest infection in the blood. He improved, but the chest lesion was not disappearing. The new lesions were coming. So we asked the medicine department, what should we do? Can it be COVID? So they came and saw, we did the throat swab. It turned to be COVID positive. So we have to quarantine so many nurses and a few physiotherapists and few doctors we have to quarantine, and immediately he had to be shifted to the COVID area. So it is a real issue, major issue. Even if you screen early, and then you treat them for stroke, you have to be on a constant vigil. The patient may develop COVID even within the hospital. So these are some of the challenges. One, there was a reduction in number, which has improved, I would say. There was a system change within the hospital. Every hospital has to reorganize the screening system and the emergency healthcare system. And then the nurses, the doctors, the technicians, all have to be trained. So it was a big effort together to treat these patients.
So I would really appreciate Dr. Pandian and all specialists who has been treating stroke in the era where we don't have awareness among the people. So coming to my second question of the session, do you think there is enough awareness about golden hours among general public? How do you feel that layman person can come to know about someone is suffering about some stroke
Yeah.
attacks, right? So there are two different point perspective to it. One, we are still living in very less awareness. We cannot differentiate between heart attack and stroke attack. We awareness, if we talk about awareness level of normal people, it is pretty less. And coming to the second situation where we are facing COVID-19 situation, people don't want to come out of their home, go to hospital for small symptoms. Sometimes the symptom get mixes with their normal symptoms of heartburn and something like that. So how do you tackle the situation? How are you making people aware about golden hour generally before COVID-19 times and now after COVID-19, how people are taking this, how seriously people are understanding this?
Yeah, pre-COVID, yes, the general public largely are not aware of stroke warning symptoms and signs. The main reason behind is that it's very easy to recognize heart attack. Okay, you can educate them. Now, if you have chest pain and you have sweating and the pain radiates to the arm, left arm, then you are most likely you're going to have a heart attack related problem. But on the other hand, because of the stroke, which presents in multiple ways, and even if you raise awareness, it is very difficult for people to recognize whether they have stroke symptom or not. So many efforts have been taken from Indian Stroke Association and also World Stroke Organization. We have done multiple campaigns, but it was not a very concerted effort. Through World Stroke Organization, we have a World Stroke campaign, which every year, October 29th, is celebrated as World Stroke Day. Globally, the stroke awareness is, many activities take place and awareness improves. And what we call stroke champions across the country, wherever we are placed, a neurologist or physician, we constantly do public awareness campaign, either as media or in the social media or in the press media, multiple campaigns or focused education programs or a stroke support group. Through them, people do a lot of educational activities. Compared to previous years, definitely there has been improvement in awareness. If I take Ludhiana, I know that because of the multiple awareness campaigns that we have done in the past, people are aware, okay, if I have a symptom of stroke, I need to get one drug. They know, ek tika lagana humne. Ye 4.5 घंटे के अंदर. So there is some awareness, but it is not enough. I know for a population like India, number one, we don't have so many stroke centers in the country. Most of the centers are located in the cities and in smaller towns. We are trying to educate people, physicians, number one, and so it's a long process. So even in the pre-COVID time, it was a big challenge. Post-COVID, again, I would say we have done in a small way, like do not stay at home. If you have a stroke, please reach the hospital on time. Globally, World Stroke Organization has done this, and also many regional country organizations have taken this step. Recently, we have just initiated one program where don't stay at home campaign. If you have a stroke, don't stay at home. So that probably should be launched next week. It's from the doctor's side that it's going to come in the social media and also in the press media. So these are the measures that we are taking. Even in Ludhiana itself, I have done at least 2 or 3 press releases. Why you need to take care of your risk factors like hypertension, diabetes, and if you have any of these symptoms of stroke, you don't stay at home, come to the hospital on time.
So while we are talking about making people aware about stroke attacks or golden hours, I will not leave this chance for my viewers to know what are the common symptoms of a stroke attack.
Yeah, so the common symptoms are a sudden weakness in one side of the body. That will include face, arm, and leg. And the second one is sudden numbness in one half of the body. what they call sunn ho jata hai,
Mhm.
sudden numbness. And then sometimes if they have a weakness in the right side, they can have trouble speaking. So there are three types of difficulty people can have. One is they can't speak, but they can understand. The second is they can speak, but they can't understand. So that means, if you ask a question to them, they will say something else, but they're able to express. And sometimes you have both the things that will be lost. So
Mhm.
you ask them, they won't be able to understand, they won't be able to speak.
Mhm.
So these are the common symptoms. And the face suddenly deviates like this. If one side is paralyzed, the other side pulls, and sudden loss of consciousness, sudden giddiness, vomiting, imbalance. So these are the common stroke warning symptoms and signs.
Mhm. Coming on the stroke attack, post the stroke attack, now patient comes to hospital. So to know, in this bigger population, we have something called stroke treating center. What are those stroke treating center? What is the specialty? What composes those stroke treating centers? Is first question. Followed by how many stroke treating centers we have in the country, and what is the way to go?
Yeah. So the stroke there are many terms people use.
Mm-hmm.
Stroke ready hospitals, stroke treatment centers. What I would say is stroke ready hospitals, which applies to India. But if you take US, they have a comprehensive stroke center and a primary stroke center. There are
Mm-hmm.
two things they have.
Mm-hmm.
So if you take stroke ready hospitals, the hospital should have a CT scanner.
Mm-hmm.
Hospital should have a dedicated neurologist or a physician who's trained in managing stroke.
Mm-hmm.
Hospital should have a stroke unit, a dedicated area where they can keep stroke patients, 6 beds or 3 beds, whatever it may be. And they should have dedicated team of nurses, physiotherapists to manage these patients. Some
Mm-hmm.
basic facilities like a monitor or one or two ventilators to take care of very sick patients. And
Mm-hmm.
the thrombolytic therapy, like what we call intravenous injection, TPA,
Mm-hmm.
that drug should be available. And uh, for a higher center, a bigger center where we can, if you have a facility for a DSA lab
Mm-hmm.
to do brain angiogram and pull out the clot using a stent retriever. So
Mm-hmm.
that is the next level.
Mm-hmm.
And if you have that level of facility, you need to have a neurosurgery department. Some of the strokes you need to do surgery.
Mm-hmm.
So I would say if there is a CT scanner or a physician or a neurologist who's ready to treat stroke patients at a dedicated stroke unit with some nurses and physios, that is sufficient to say that this is a stroke ready hospital.
Mm-hmm.
And in terms of number of stroke ready hospitals in this country, I would say based on, we have one initiative called Angels Initiative,
Mm-hmm.
where stroke ready hospitals are enrolled in a national database, or it's a global database
Mm-hmm.
where people enroll their hospitals and they follow standard key performance indicators. So
Mm-hmm.
there are close to 400 stroke ready hospitals in this country. And there are many outside this network, maybe I would say close to 500 stroke ready hospitals
Mm-hmm.
in our country. For a population of 1.3 billion, it is very, very less.
So miles to go in this, and this poses
Yeah.
my next question to you: that what measures do you feel Indian healthcare system can take to better handle the stroke cases and save more lives?
Yeah, I would say one is uh, even though the healthcare system in India is largely private, but very large proportion of patients go to government hospitals
Mm-hmm.
because they can't afford. And so we need to really strengthen the government hospital system.
Mm-hmm.
So we have started this initiative of through Indian Stroke Association and many of our neurologists who are interested in stroke. We have developed stroke care programs in district government hospitals in the state of Punjab, Himachal Pradesh, Uttar Pradesh, and a few states in Northeast India and in southern part of India. So it is growing. So this is from a personal initiative. Now it's not from a top-down approach,
Mm-hmm.
but more and more state governments, we are able to approach the NCD nodal officer and the DHS, and they are, when they show interest, we try to develop through the local champion and So it is growing, I would say. This is from the government side, but in private setup, it is just catching up. I would say, people know the potential of this particular treatment and the benefit that patients can receive. So there are a lot of private hospitals, they are catching up in developing a stroke program. But the strength of our country would be if every state or at district hospital level, if you create a stroke unit, that is the best model for our country where we can improve the stroke care.
So thank you, Dr. Pandian, for this wonderful insights which you have given on stroke care and stroke pathways. I'm sure this would help people to be more aware about the stroke attacks, and people will take timely action which can save millions of lives. Thanks a lot, Dr. Pandian, for throwing those insights.
Yeah.